Then, so the number one cause of classification system is to detect the fracture pattern in a same way all over the world. So we can speak in same language. Suppose an A2 type fracture. So everyone can understand, yes, this is A2 type from all over the world. And also the prognosis and treatment strategy, fixation strategy, everything. So that's why we need to know the classification system. So let's start with the AO classification system. So there are basically three common types. Number one, the A type, it's the compression injuries, in case of which the interior structure are failed under compression, as you can see in the figure A. This is A type. Okay. The number two is the B type fracture, the failure of tension band. Now, tension band is two types, actually, anteriorly and posteriorly. Two types of tension band injury. I will discuss it later. Number three is the C-type injury, when all the elements of the vertebral column are dislocated or displaced. That is C-type, and it is the most severe type injury. So A-type is again subdivided into another 5 types. Number one, A0. A0 is the fracture pattern. Actually, it is a very insignificant fracture. It doesn't provide any kind of unstable to the vertebral column. So A0 is the minor non-structural fracture. That is, you can say the spinous process fracture or transverse process fracture. This is A0. Then A1. A1 is the wedge compression fracture, where you can see that single end plate is injured without involvement of the posterior vertebral wall. So you can see in the CT scan also, there is a fracture, compression fracture, the upper end plate, but without involving the posterior vertebral wall. That is A1. Number two is the A2. It is split fracture. Here you can see both end plates are injured, superior and inferior, but still posterior vertebral wall is intact. This is A2 split type or pincer type fracture. Number three, A3, that is called incomplete burst fracture. As you can see here, the end plate is injured, the superior end plate is injured along with the posterior vertebral wall. Okay. So this is A3, incomplete burst fracture. So what is complete burst fracture? Very easy now. If the both end plate is injured and along with the posterior vertebral wall, that is called complete burst fracture or A4. You can see here the both end plate injured along with the posterior vertebral wall. And there is another picture which shows a vertical sagittal fracture, which involves superior and inferior end plate along with the posterior vertebral wall. So if we can recapitulate, so this is the A0, where the transverse process or spinous process fracture. The A1 is the superior end plate fracture, A2 both end plate fracture, A3 superior end plate fracture with posterior vertebral wall involvement, and A4 both end plate injured along with posterior vertebral wall. So this is A-type injury. A-type is only a less. Can you understand me? Yeah. Okay. So now we move to B-type injury. So this is the tension band which I talked earlier about. So when the anterior longitudinal ligament is ruptured, this is called anterior tension band disruption. And when the posterior tension band is disrupted, it includes the posterior ligamentous complex from the supraspinous ligament, interspinous ligament, facet joints, ligamentum flava, and posterior longitudinal ligament. These, along with the spinous process, these are the comprises posterior tension band. So let us see. Number one, B1 fracture. You can see here. Number one, B1, it is transosseous along the bone only. No ligamentous involvement is here. This is also called chance fracture. So this is B1. Okay. Now, this is B2, both bony and ligamentous. How do you know it is ligamentous? You can see the MRI and you can see there is a signal intensity, high signal intensity in the fractured level. So there is injured PLC. So this is osteoligamentous, posterior tension band disruption, that is B2. And number three, this is anterior tension band injury. It usually occurs in ankylosing spondylosis, hyperextension injury. When there is a disrupted, the anteriorly through the disc and disrupt the, you can see the arrow, chopstick fracture in AS. The anterior longitudinal ligament is disrupted. So this is hyperextension injury, B3. Now the last is displacement and translational injury. When the whole elements are disrupted, then it occurs. It is called C-type injury. You can see the translation or along the sagittal band, rotation, and everything. Usually presents with Asia grade A, usually. So this is the AO type, AO classification system. So if we see the algorithm by a hierarchy system, first we indicate if there is any dislocation or displacement. Now, if you have displacement or dislocation in the X-ray,
Mohan bhai, ekটু interrupt করি.
yeah.
So the thing is, this kind of classification is usually kind of boring for us, for juniors and for everyone. It starts from A and various subclass classification and then ends with C. So it becomes sometimes very difficult how to apply it practically. So this algorithm will help all the audience to apply the classification system practically. Where so every participants are requested to look at this algorithm where to start, so you can get a very good guide on how to classify this kind of injuries. Only please proceed.
Yeah, thank you, Jay. Yes, it is very boring, but you can start with the seeing the X-ray and CT scan. Okay, first you see for displacement or dislocation. Is it present or not? Okay. So if there is any kind of displacement or dislocation, if it is present, then you can sure it is a tension band injury. Sorry, translational injury. That is type C, the most severe. If it is not, you look for the tension band injury in the X-ray as well as in CT. Okay. Also in the MRI also. So if there is a anterior tension band injury, you can say it is a hyperextension. B3. If you can recall this, hyperextension injury is B3, anterior tension band injury. Now, if it is not anterior, but posterior tension band injury, then is it involve both bony or ligament or both? So if it is only bony involvement or osteoligamentous, if it is an osteoligamentous involvement, then it is B2. Okay, and if it is only bony, then it is B1, pure transosseous disruption, as you can recall from. So if there is no displacement, no tension band injury, so this is vertebral body fracture. Yes. Okay. If there is any vertebral body fracture, then you have to see if there is a posterior wall involvement. Now, the residents or my colleagues here, if there is a posterior wall involvement, so the type of injury would be which type? Jia, Miss Dr. Jia. So if the fracture involve the posterior wall, what are the types?
Yes. So when the fracture involves the posterior wall, then it is automatically goes into a burst fracture.
Yeah, that is A3 or A4. Posterior wall involvement injury means it is A3 or A4. Now if it is single end plate, that is A3, and is double end plate injury, then A4. Okay. So you can see both end plate injury is complete burst fracture. If it is single end plate, it is A3 fracture. So there is no involvement of posterior wall. So it is only end plate injury. Yes. So both, if there is both end plate is injured without posterior wall involvement, then it is split fracture A2. And if it is only single end plate, that is waist fracture or impaction fracture. Yes. So if there is nothing in the X-ray or MRI or CT scan, only vertebral process fracture, so it is A0, insignificant injury. So if there is none of the feature present in the X-ray, CT or MRI, then there is no injury. So this is the algorithm actually follow in our clinical practice. So up to this slide, do you have any difficulty to understand your classification system, please?
So thank you, Mamun bhai. This is a very nice demonstration of the classification system. I would like to stay with this slide for a while, so that if anyone have any doubt or anyone need any tips how to classify a injury, he can ask a question here. Here the question and answer session is open. It will be open for 5 minutes. So any participants, respected seniors or colleagues or juniors, you can come up front with your question. So you can unmute yourself and you can question, or you can write in the question in the chat box also. Rabbu, can you hear me, Rabbu?
जी
Yes,
सुनते
Rabbu.
पाচ্ছি
So you don't have any. If you don't have any question, then I have a query. So if you get a spinal injury patient in front of you with imaging, so how will you start your classification? Like how will you proceed with the classification? Like you cannot say straight away it is a A4 fracture in the middle of a very busy ER department, right? So where to start? So this is the point we want to notify here to everyone, that how to start. And basically I am telling you that we all should take it this algorithm very seriously. So where to start? Where would you start with the X-ray or MRI for classification, Rabbu? So this is not necessary that you take pressure and you have to answer. This is a friendly session, so you can hand over to anyone, no problem.
usually we do classification by seeing usually X-ray based classification, and then we need MRI for tension band or
That is okay. That
soft
is okay. That is okay. I know that you know that. But this AO system, you have to start with this algorithm. You have to start with whether there is any translation. I mean, anterior, posterior, or lateral translation is present or not. If not, then what you will see? You will see the tension band. I'm not going into the subgroup. So at first you will see the translation, whether it is C or not. So you will start from, from C.
More
And
severe
you will,
injury.
yes, more severe injury will start from. So you will look for any displacement or dislocation. If not, then it is not a translation. Then you look for the tension band. I mean, whether it is a B or not. Then if your tension band is okay, then you move towards the A. So whether any vertebral body fracture. And if the vertebral body fracture, you look for the posterior wall. If the posterior wall is intact, then you see whether the anterior wall. So this algorithm, in a rough, you should start from C, and you should move towards the A. Then you will find it very easy to classify a injury.
Thank you, Jia, for your nice first.
So,
The one
you
thing
have any question, you can speak up.
Zia bhai, I have a question, or I want to know something.
Yeah, sure.
That this classification, I think it is very difficult to diagnose once by seeing only X-ray in the emergency
Yeah,
room, and
yeah.
because translation and osteo ligamentous disruption, also the complete or incomplete burst fracture, maybe it will be clear after seeing the CT and MRI.
Yes.
So here, Dr. Jia, I want to add some points here. This is a very good point we indicated there. So you only see the X-ray in the emergency department. So only seeing the X-ray, you can assume the fracture type, but you cannot be sure. Okay. Only you can sure about the translational injury. Other
Yes.
than this, if you can differentiate them, it is only by CT scan and also with the aid of MRI. So you can only assume by X-ray. Yes, this can be a translational injury, but whether it is tension band injury, yes, anterior tension band injury you can identify in the X-ray. But posterior,
Yes,
you have to see the CT scan as well as MRI. Okay. Also A-type fracture. A-type is purely dependent on the CT scan. Thank you.
Yeah, so another question asked by Dr. Ozerem Dostogir sir. Please share the limitation of the US spine classification. So this is a very, very, very good question. This is a faculty level
Yeah.
question. So
Yeah.
the question is a very tricky question. So
Okay, Dr. Dostogir, thank you very much for your nice question. Actually, this is,
very good question.
yeah,
So
you want to add
Mohammed,
something?
you want to answer, or I proceed with the
Oh,
answer?
you go ahead, please. No,
I
go ahead.
would like to answer this question because I find this question very interesting. So what
Okay,
happens?
okay.
What happens? This is a more of a structural classification.
Yeah.
So look at the column on the right hand side. It is translation, hyperextension, osteoligamentous disruption, complete burst, split, waist. So all are the structural, or all are demonstrating towards the injury. Okay, so no one classification is demonstrating to the condition of the patient, and no one classification is demonstrating towards the neurological status of the patient. So this classification system has a very huge limitation, that it cannot define the neurological level of the injury. So sometimes even in the word we can find that only cord injury, nothing in the vertebral body, nothing in the transition band, nothing, only acceleration deceleration type of injury causing a cord hematoma, or sorry. So this classification system will only address on the structural damage, and it is not addressing towards the neurological level. So this is one very big limitation I find in AO classification system. And if Dr. Maun bhai, if you want to add anything, you can proceed. But
Okay,
my
yes.
point is the
There are,
neurological
okay,
system.
fantastic. Jia, you are right. This is the most important limitation, but AO is trying to improve every day as we talk. Okay, so there are some modifiers now, and they still, to the best of my knowledge, I think they added the neurology recently. Most recent publication has already published. So for the sake of the time constraint, we are not sharing this. Okay, so neurology is added, and it will be improved day by day, I think.
Yeah. Okay. Okay.
So
I
we
think
can
we can
move to the
proceed.
next
We
slide.
can proceed with the next slide. Yeah.
Okay, thank you very much. So next is the TLIX classification. This is now bread and butter of the all spine surgeons all over the world follow the TLIX classification because it actually involves everything: the morphology, the soft tissue, the neurological status, everything. So the morphology is the pattern. As you already knew about the AO classification, so there is compression, burst, translation, and destruction injury, and each of them have some points, and it can be shown by CT or radiograph. So compression injury is 1, burst 2, translational is 3, the point destruction is 4. So the more severe the point is more, okay. The less severe point is less. Usually seen by radiograph and CT. It is the fracture morphology, the immediate stability, okay. Now the intricate of the PLC. So I can show you the step by step. Now the morphology. So single compression, 0.1, burst fracture, 0.2, and if there is any translation, it is 3, and destruction, there is 4. So these are the things. So these things can be seen in CT actually. Radiograph cannot show everything. So CT is very necessary to identify the morphology. So the points. Number 2, the PLC. It gives the long-term stability. You can read a line in the APLE that the bony injury is healed, but the ligamentous injury won't be healed. It is written almost 3 or 4 times in the spine chapter. Okay, so PLC is, if it is intact, it is 0. suspected then 2, and injured, it is 3. It can be delineated by MRI. Now, when to suspect and when can you see it is really injured? So it is especially in MRI. And what is the surest sign of PLC injury, if anyone can ask? Then it will be during the surgery. When you see PLC is disrupted, then only you can be sure of that. So what is PLC? The posterior ligamentous comprises of ligamentum flavum, as shown number 1. Number 2, the interspinous ligament. Number 3, facet joint capsule, bilateral, and the supraspinous ligament. If any one of them is injured, then it is PLC is ruptured. Okay, so the most important of these 4 or 5 ligaments is the supraspinous ligament. When you can see in the MRI, the supraspinous ligament is injured or breaked, then you can say it is PLC is definitely injured. Okay, other than this, you cannot surely identify. Okay, so during the case discussion, we can show you the PLC injury. So now the last is neurological status. When there is no neurology, it is intact, so it is 0. If there is any nerve root injury, the point is 2. Then complete cord injury, it is 2. Incomplete cord injury, 3, and chorda equina 3. And now you can ask me another the question why there is 2 and 3. That is later on. So nerve root injury is 2 and complete injury is 2. Both are equal. And incomplete injury is more. Chorda equina is more because they are the more severe injuries. So when we all calculate them, all adding them together. So when you say that this fracture needs surgery or this fracture can be treated conservatively, there are some point systems. So if it is 0 to 3, all 3 add 1 to 3, and it is less than 3. 3 or less than 3, it is non-surgical. If it is more than 4, it is surgical. And if it is only 4, then it is your choice. If you have the ability, if you have the expertise, if you have the facility, then you can do it. So this is all about TLX classification. Again, 0 to 3 non-surgical, more than 4 is surgical, and 4 is your choice, whether to go for surgery or not. So up to this is very easy, I think. So if there is a question, you can ask me or Dr. Jia. Jia, please.
Yeah, thank you, Mamun bhai. That was a very nice demonstration. So basically, what happens? So the classification system, when you read it, you find it very boring. At least I find it very boring. But the tricky part is if you can somehow you can acquire the knowledge on classification of an injury, the decision making becomes very easy, and decision makings become very authentic. Sometimes you will find it very difficult to make a decision that how to go on with the treatment option, how to manage a patient. But if you can add one or two classification tools in your knowledge, and it will be very easy for you, and as well as it will be very medico-legally accepted. Like a fracture came to you and you operated, sometimes one of your colleague will tell that this fracture has no indication to operate. But if you know the classification system and you decide accordingly, then you will find it very easy. And of course, for our resident colleagues, for during your exam, if you can at least acquire this TLX classification system, you will find the thoracolumbar injury decision making very easy. So thank you, Mamun bhai, for your nice demonstration. So one thing is that the limitations of the AO classification somehow is overcome by this TLX classification because they put the neurological status also into the play. So now we'll show some cases, basically not a lot of cases because we always want to make this kind of webinar very easy going, and that the webinar don't get boring, so the people come here and we can discuss. So Shah M. Faisal sir, you have any comment on this last part of the discussion?
No, actually not. But neurology should be addressed
Yes.
along with the anatomical classification that you has provided.
Yes.
Okay. That's
So,
it.
and I would like to thank you again for joining today. You are with us from the beginning. This is our second session, and you are present here. So we feel very proud that you are here.
You-
So next moves to the next slide, Mounty. Next slide. Okay, so this is a case. So not a very big case or very complicated case we will discuss. We will discuss simple cases. So this is a 28 years male. He's having a burst fracture of lumbar 1 vertebra. His PLC injury present, and Asia grade is Asia C. So can anyone do the TLX scoring here? I would like to invite any residents of us to come forward and do a TLX scoring. Maybe we don't have city here, so this is our limitation. But still, we can manage with this kind of X-rays and MRI. Anyone, please come forward with the TLX classification. TLX score. Anyone can make your TLX score. Please come forward. Khalil bhai, can you please come forward?
So anyone, what are the morphological points? For morphology, what point do you want to give this fracture?
Yeah.
Already is written burst fracture.
Yeah, burst fracture. So for
Yeah.
burst fracture, what is the score?
What is the score?
Two. Burst fracture 2.
2. Okay.
Yes.
Khalil
Yeah,
bhai
yeah,
is
yeah.
getting very nice. And the PLC injury is present. So, what is the score?
PLC complete injury, so that's 3, 4.
PLC for PLC it is 3. Okay. So
3.
PLC.
And incomplete 3.
okay.
Okay.
And neurology incomplete injury 3.
3. Okay.
Incomplete
Yes.
cord, right?
PLC injury is
Incomplete.
there, so it is 3.
3. Yes.
PLC injury incomplete means
No. Incomplete
PLC.
neurology. I mean incomplete.
No, PLC injury.
Incomplete neurology. Neurologies are incomplete.
intermediate,
Three.
suspected, but or disrupted. Intermediate means suspected, but disrupted means it is MRI documented.
Okay. Dr. Ripon Ghosh. Is it
Welcome, Dr. Riponda.
another learned person?
Thank you.
So,
Yeah.
Jia, can you see my cursor?
Yes, we can see.
So this is this black line. This is the supraspinous ligament. Okay.
Yes.
Yes. So this one is intact. The black shadow. This is
Yeah.
interspinous ligament. The black shadow.
Yes.
And it is not. You can clearly see the interspinous ligament is ruptured. Okay.
Yeah,
Along
there
with the
is
ligamentum flava. ठीक है? Is it
Yes,
understandable? Okay.
Yes.
Okay. So the
this is
total
a
point.
the score is 3.
Yes.
And the neurologically, this is an incomplete cord injury, so the score is 3. Okay, so this is the score is 8. So the decision making is like a piece of cake now. Now the decision making is surgical. So next move to the next case. So this is another case. He's a 36 years, still the burst fracture. So again, I am sorry for not having the CT scan here, but still it is a burst fracture because we are not going to the description for burst fracture, but burst fracture is present here. PLC injury is present, and this is Asia B injury. So anyone, please come forward with the TLX score.
বাস ফ্র্যাকচারের জন্য এখানে টিলিক্স স্কোর হবে মরফোলজির জন্য 2, পিএলসি ইনজুরি যেহেতু প্রেজেন্ট 3 এবং
Great.
ইনকমপ্লিট স্পাইনাল কর্ড ইনজুরির জন্য 3, সো 3 3 6 and 2 8, টিলিক্স স্কোর 8.
Yes, he is right. But there is a printing mistake. I think it is not complete cord injury. It is incomplete. If it is Asia A, then it is complete cord injury. Okay, the scoring is right. Okay, so this is 3 actually. Score is 8, and decision is still surgery. Right, Jia?
Yeah, right. Correct. Sorry for my mistake.
Okay, no problem. So carry.
Next move to the next case. So this case is a 39-year male, still the burst fracture same, but here we didn't find any PLC injury. and patient has a lumbar 3, 4, and 5 nerve root weakness. So now Rabbu or anyone, please come forward with the TLX score.
For বাস ফ্র্যাকচার মরফোলজির জন্য for বাস ফ্র্যাকচার স্কোর হবে 2, যে no PLC injury, so score 0. L3, L4, L5 weakness, that indicates
Root
incomplete
injury.
spinal cord injury.
No, this is
Root
only,
injury. For root,
Root injury.
score 2.
only root involvement. So it is 2, right? So the total score is 4. So what is the decision?
Surgeon choice. It depends on surgeon choice.
Yeah.
I want to know here how you evaluate the patient, is it a root injury or not?
So this is a root injury is documented from the clinical examination. So this
Okay.
patient has a lumbar 3, 4, and lumbar 5 weakness. So we have to assume that as the injury level is lumbar 2, where the cord basically ends in lumbar 1 and lumbar 2 level. So lumbar 2 is mostly there is the end of the corda equina, end of the conus and starting of the corda equina. The roots, only the roots are available here. So, and the clinically the patient's only having specific root weakness, nerve root weakness. I mean the specific muscle weakness. So that we can understand from here that this is a root injury. Or Dr. Ripon Ghosh, yeah, if you have any other idea here or
Okay.
any other
During ward round, I have seen some patient, only one patient, many times I have seen that one limb is, lower limb can move, only flickering movement, and another limb cannot move, 0. At that time, sensory motor is 0 in right limb, suspected that another limb he can only move. At that time, you can see the X-ray and the injury level is L3 level. So you can think it is root injury.
Dr.
But
Ribon,
sometimes
if there is motor 0 in one leg and another leg is completely normal, is it?
sensory motor both are 0 in one limb, and only motor is present flickering movement in another limb.
Okay,
In
okay.
L3, L4 level. I have seen lots of patients in ward. At that time, I think the resident also completes
Yes, yes,
complete injury or incomplete injury.
Riponda is absolutely correct. I have also seen this kind of injury. That there is a injury on the L2 or L3. One limb there is like a few neurological involvement, like few roots
So it
injury
is
or
a purely different topic. It is
yeah.
actually Asia grading.
I just want to
Yeah,
give
yeah,
my
Asia
point.
grading technique. Yeah, yeah.
Yeah, I
Where
just
you,
want to give how it is possible.
I have
So,
a question.
yeah, yeah, it's
May
possible.
I interrupt?
yeah,
Yeah,
sure.
yeah.
Assalamu alaikum.
Yeah, welcome.
I have a question that in case of Telex score 4, how do surgeons make choice? Like whether he has to go to conservative or surgery?
Yeah.
Very nice
What do
What
you
is
want to
the
answer?
main determining point
Yeah, yeah.
that surgery choice? Yeah.
So number
Okay,
one.
thank you.
Number one is a high demand patient. It is poor actually if he easily can treat him conservatively. But if he is a high demand patient, you want to go back his normal life early. In that case, you should fix it. Okay. Or if you can see if there is any chance of progressing the deformity. Suppose the bone quality is very poor, you have to treat it early. In case of osteoporosis, so there is a chance of progressing the kyphotic deformity. So sorry. Okay, so these are the actually more points to go for surgery. Actually, you have to have all the facilities also, expertise, facilities, and everything, and as well as the patient factors, the patient high demand patient, and the bony configuration. You have to consider the bony configuration as well as the patient demand. Okay.
Yes. So one thing
So if you can add another point, Dr. Ripon, Dr. Jia, or any other.
Yeah. So I always believe one thing. So I was like, I want to tell a small story. So I was presenting in some conference. some MIS case, and his score was 4. And I operated and I presented and some senior faculties. He asked me why you operated. It does not have any indication. So sometimes, my answer was like that. The scoring systems and all the classification systems, they're made by the Western people. Okay, so they may not think about our male person who is the only earning member of a family. So I would like to operate him because he is the only earning member of the family, and he would love to go back to his work for the sake of his family, so that I can make him work on the day 1 after surgery. So when your TLX score is 4, always I believe that the patient's factor come into play. That whether the patients would be benefited by lying down for 3 weeks, 4 weeks, or he will be benefited by
Maybe 6 weeks at least.
so that is also, this is like a question, very important. Dr. Rahat have asked. It's a very good question. This is always a very doubtful thing, that whether I should operate or whether I should not. But the scoring system demonstrates that if your score is 4, you can you can add other factors, or you can add your opinion with the logic. So whether the patients can be benefited from your surgery, or whether the patients can be benefited to go back to his work very early. So uh, total score 4, my opinion is I would like to go for surgery always, because I don't want to make a patient lying for 3 weeks, 4 weeks. But below 4 you cannot do surgery, but with the score 4 is still the same. If you want to conserve, you can conserve. So according to this scoring system, but still there are many other scoring system, many other thoughts can come into play. Dr. Riponda, if you want to add anything, this is a very good question, I think, and I think you can give some input here.
No. I am agree with you. Yeah.
Yeah, okay.
You're
Okay,
right.
so let's proceed, Mounbhai.
Okay. So the approach,
Yeah,
I'm going to, or you?
go on, you go on, no problem.
Okay, the approach are already you know. Some of you know still. The anterior surgery, you can go anteriorly or go posterior or go combined. So not going to in details, going to which. So the fixation strategy, you can go for long segment fixation system. In case of unstable fracture, in case of osteoporotic fracture, if there is ankylosing condition or dish, then you can go for long segment. And I think everyone knows what is long segment fracture fixation, which is 2 level up, 2 level down. I think you know it, okay? We can discuss it later. So this is the long segment fixation. It is usually used in unstable fracture, osteoporotic fracture, ankylosing fracture, and of course, in case of C-type injury, AO type C, translational injury, we should use long segment fixation along with bone graft. So number 2 is the short segment fixation. Here you can see it is only 2 screws above and 2 screws below, total 4 screws. This is short segment fixation, usually done in AO type A or B fractures. Number 3 is the short segment and incorporation of the fracture vertebra. In this case, we include the fracture vertebra within the constraint. So now the decompression strategy, whether you go for decompression or not, I am just talking about what are the types. So whenever we go for surgery, there is some decompression. You have to have some decompression. Either it is indirect or it is direct. 2 types of decompression: indirect decompression and direct decompression. You can see here the incomplete indirect decompression. Here we put screws and rods and distract it. Then the ligament causes the bones to go back their normal position. As you can see here in the CT, the retropulse fragment within the canal and almost complete occlusion of the spinal canal. But after indirect decompression, it almost go back to normal position. It actually works like this. You put X-ray, you put the rod, and you distract it, and it goes back to the normal position. There are some conditions you can go for indirect decompression. Actually, when there is no deficit, if the patient have no neurological deficit, you can go for indirect decompression almost every cases and some other selected cases. Now, what is direct decompression? The direct decompression is you have to decompress everything. Actually, the retropulse fragment which causing the deficit, you have to remove the fragment from the canal directly. So you have to do the laminectomy and removal of the compressive fragment. This is direct decompression. You go for only decompression, the posterior decompression, and do not take out the compressing bony fragment. That is not direct decompression. That is just a modification. You have to have removed the retropulsed fragment. So this is one of the type of direct decompression. And another type is the transpedicular. It is also decompression, direct decompression. It can be done by the pedicle. Transpedicular means through the pedicle. Through the pedicle, go and take out the bony fragment. There are some other procedures modified by our dear sir, Professor Dr. Muhammad Shalom. He decompress and push the retropulse fragment back to the body by pinching it. Yes, there's an instrument, and he push back the bony fragment with that instrument by hammering it. Okay. So two types of decompression, one is indirect and one is direct. We do the direct decompression in case of reverse cortical sign. If you have seen in the CT scan that the reverse cortical sign is present, the laminar split side is present, and the patient have the progressive neurological deficit, then this is, you can go for direct decompression. So progressive neurological deficit you can see and assess by neurological examination, and the other two you can see by the X-ray, so CT scan. So what is reverse cortical sign? So there is a fallacy. Look, there is two terms, reverse cortical and pseudo reverse cortical. I will go one by one. Now, this is one thing. The fragment of the posterior vertebral wall, it is rotated 180 degree, freely lying within the canal, okay, and the cancellous part facing towards the port. I will tell again, the posterior border bony fragment is rotated 180 degree, lying freely within the canal and the cancellous part facing the port. This is true reverse cortical sign. There is no place for indirect decompression in this case, though it is rarely found. Now, what we actually found in our practice, most of the daily practice, we have actually the pseudo reverse cortical sign. One, if you see the top photo, the axial cut of the CT scan, you can see the canceller part is facing to the canal. So it is reverse cortical sign. But if you see the sagittal view, the section taken is the inferior border, and it is not even rotated 60 or 90 degrees. So it will never be a reverse cortical sign. It is a pseudo reverse cortical sign. It works just fine with indirect decompression. Okay. So Jia, if we have a patient with spine injury, thoracolumbar injury, if there is no deficit, we don't have to do any kind of decompression. That means no direct decompression. Indirect decompression is sufficient, and ligamentotexis can be done in the most cases, and it is as effective as direct decompression. And if we want to avoid direct decompression, and save our operating time, we have sought this patient very carefully. And CT scan is a must. It's a must to determine the fracture type, so that you can plan your treatment strategy and fixation constraint as well as decompression technique. Thank you, Jia. If you can add something, please carry on.
Yeah, so very nice, Conroy, very nice. You have presented almost everything needful for our juniors and us. There are many more talk and many more issues in spinal injury. I know, we all know, but still, the most important parts I think is discussed here, and we have many learned faculties here. I can see Purnendu sir also, uh, and Shah M. Faisal sir is also here. In fact, Professor Shahram sir also, he also joined, but somehow he got disconnected. We are very unlucky. We would love to hear something from him. So now the final part, we have finished it because we have told at the start that we will make it very short so that nothing gets hampered in daily life of an orthopedic surgeon or any trainees. So let's finish with few questions. I would love to hear some questions from our orthopedic trainees or residents, or even any faculties. I would love to hear some question. So please ask anything. This is not a class, this is only a discussion, this is only uh, a platform whether we can discuss spine surgery. So residents should have a lot of question on decompression things and short segment or long segment things, because every day before a presentation, I find some WhatsApp emails, um, by what should be the plan, whether it is long segment or short segment. So let's discuss it here, because here we will find some more faculties to answer. Anyone can ask anything, please.
Thank you so much for a nice session. And I have learned so many things from this webinar, president webinar. And I have one question. What is the ideal protocol for conservative treatment in case of minor trauma, spinal trauma? Uh, and
So
second question,
can you tell which A type you are demonstrating, like A0
A,
or A1 or A2, which A type?
A type, A type A1, A2. For
Okay,
A type A1, A2.
okay, Mohan, please answer.
Type A1, A2, actually, it can be treated conservatively. Yes, it can be treated conservatively. You can give him rest for 6 weeks, and later you can ambulate or work him up. So there is no harm. If it is the fracture pattern is stable, we have to assess the fracture pattern actually. Is it going for other deformity or creating other deformity or not? If it is, you think it is stable, it is stable enough, there is no ligamentous disruption, then you can go for conservative treatment,
So
especially in A0,
he's
A1, and
basically
A2.
asking, Mohan, let me stop you. So he's basically asking the protocol. What would you do for the managing the patient? He is agreed with you the conservative
Here,
treatment, but
Yeah,
what
yeah.
here
conservative protocol? Yeah,
Of
here
course,
I want
I
to
am.
ask.
I was telling the same. Okay.
yeah,
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 Dr. Ripon Ghosh, you are want something to say?
Yeah, I want to know from you that what is the chance of post deformity in case of A1 and A2 fracture? I do conservative treatment in
Yeah,
A1,
yeah. A1, A2 is
A1 or
conservative.
A2.
Of course, of course.
What is the
Sometimes
chance of
A3. So many a times,
there
Dr.
is
Ripon and
no
I
chance
used
of
to say,
deformity in
yeah,
A1 and A2?
yeah. No. A1, A2 actually is not usually go for any kind of deformity. It
No,
is
no.
actually A3
There,
type.
there are lots of
But
journals that they told that you should think about the age of the patient, quality of the
yeah,
bone, and
yeah,
uh,
yeah, yeah.
if the
I,
quality of the bone is not so much
yeah.
good and bone marrow density is poor, then you should fix MS technique. Otherwise, it is 40. I can't remember the percentage of the post deformity of conservative management of A1 and A2. There is a
Yes.
14 to 20% of post. If you don't do operation, then post hyphosis may occur.
So
So
A1, A2, you can treat conservatively, but A3, in our institute, A3, and sometimes A3 is treated by conservative treatment. In some cases of B1, B1 is purely chance fracture. It is also treated conservatively in somewhere. But as the Dr. Ribbon said, there is some chance of kyphotic deformity appears. It is all dependent on the bony condition and other things, as we told earlier. But the protocol is you have to wait for at least 6 weeks. When you're going to treat the fracture, you have you have to give 6 weeks at least rest to healing of the bony component actually. Okay.
Sir,
Then you can mobilize him. Then you can mobilize him.
Bed rest only, complete bed rest, or patient can mobilize with
Patient
also
can
rest.
mobilize, yes. Bed A0, A1, A2, actually you can mobilize with the thoracolumbar port set. He can use for 3 weeks at least easily. Then he can remove it.
Yes.
Actually, it is depend on case by case. Okay, every fracture, every patient is different, and you have to assess differently and treat it. Okay.
Yes, yes. So I am totally agreed with Mount Bhai. Dr. Riponda, he was mentioning to some kyphosis in a A1 fracture. So look, kyphosis can happen.
A1 and A2 in case
Yes.
of bone quality.
Yeah,
There
yeah.
is-
So that is what I am coming to the point. So kyphosis even can occur in a patient who never had a spinal injury, right? We find a lot of elderly patient who never had a spinal injury in his life, but kyphosis comes into play. But this is due to the other factor. This is due to osteoporosis. This is due to lifestyle. This is due to metabolic bone disease and all. Many things comes into play.
I
So
want to say that bone quality should be considered in this case. If
yes,
A1
exactly,
that you should
exactly. So good point. Yes. So any
Dr. OJM Dostogir is asking a question below the level. Number one, Asia grading is applicable. If not, how can we assess neurological deficit of spinal injury? So this is not actually a session of Asia grading, but in
still you can answer.
it is theoretical purpose. Yes, Asia grade can be applicable. Okay, but its value is very less.
in some center there is also applicable Asia grading in case of
Yeah.
infection also.
Yeah.
Not only injury. Asia
Yeah,
grading
in
also
case of
can
TB.
be used in case
Yeah,
of
yeah.
infection.
So we can use Asia gradient in every fracture in every level, but below the level of L1, it is very less valuable. Okay, that is the main point. We can discuss it in another session by Asia
So
grading. Okay.
we have a plan on Asia grading, and we have a plan on discussing its separate session. So
Okay, another question from Dr. Tauhid. Ideal time for surgery. অনেক রোগী ভর্তির পরবর্তীতে অনেক
What is the
সময় লাগে।
all of you grading in case of perfect?
Yeah.
sorry, someone was asking something. Can you please speak up again, please? What was the question?
Ideal time for surgery. Yes. Anyone? So ideal time for surgery. Someone is asking ideal time for surgery. Ideal time for ligamentotexis. Okay, is it actually as early as possible? Number one. Number two, you have to manage the patient first according to the ATLS protocol. When the patient is stable, then you go for this injury fixation. Okay, it is as early as possible. There are many centers in the world, they do within 24 hours of injury, but we cannot do this. So most of the cases we face in Meteor is 7 days, 14 days, even 21 days. There are sometimes 2 years earlier, we have to do it even after 1 month, but nowadays it is more or less. So we are doing now a spine injury within 2 weeks, sometimes even within 1 week. So ideal time is as early as possible when the patient is stable. Okay. And the rehabilitation protocol is the same.
I want to add one point with Mount Bhai, that ideal time, there is a lot of controversy that the early surgery, late surgery. So even me and Mount Bhai also had some discussion during our last presentation on that. So I want to add one thing, that there is a very key point we discussed in our first meeting on spinal shock. Okay, so sometimes what happens, the spinal shock and the level of injury, it got masked. So if you do a surgery on a spinal shock, and the decision can be sometimes can get wrong. This is one point I want to add. So at least we need to wait for the recovery of the spinal shock. So we need a very proper clinical examination, whether it is a spinal shock or it is a complete spinal injury, for timing of the surgery. If you find a spinal shock, please wait for the recovery. Number one. Number two is you always have to think about the second hit. You always have to think about the second hit. That is what Maunway also told, that you have to follow the ATLS protocol. So considering these facts, you have to decide the timing of the surgery. And definitely our center does not have any, I mean, our center, I do not defame our center, because this is the only tertiary center. The patients come from everywhere. So this is not like patients coming here and we are operating within 2 to 3 days. So sometimes it is very difficult, but nowadays most of the cases we are operating within 7 days in NITR. So this is very good. So any other question, any other, if there is no question, then we would like to conclude, I think. So anyone here would like to ask any question? So our session is already 1 hour, so we can extend for 5 minutes. So if any one of us have any question or any input, please come forward, or otherwise we will end the session.
I think we should have a session on Asia bleeding and spinal shock.
Yes, we'll do inshallah. So if no one have any question, then I would like to ask one from resident, Dr. MD Mirazul Islam. Can you hear me? Is not, I think. Dr. Tawhid, can you hear me?
Yes, I can hear.
So I would like to hear one or two words from you about our session and about our about this kind of steps we are taking for learning and discussing. I would like to hear 2 words from you. So if you add some ideas, we will consider it for later on. And if you inspire us, we will get boosted. So let's say something.
It's a very nice and good initiative, and it should continue.
Okay, thank you. So I would like to one last participant from here is the most senior one I am searching for, and I am finding Dr. Shah and Faisal sir again. Would you please say something, 1 or 2 words, and then Dr. Maun Bhai will conclude.
I think you should ask our seniors and the mentor of spine surgery, like Professor Shalom sir, or maybe Shohid Akun sir or Jahid sir, to attend. I think you should ask them also.
Okay. I have asked yesterday, basically, but what happens? Every seniors, they have one opinion that this session we should do a little later, because this is a high time for them, so they are not joining. So, but we will accommodate them within near future, inshallah.
Dr. Dostagir is here. Is he hearing?
Who is here?
Dostagir.
Yes.
Please say something how we can improve.
Actually, I am not aware about the topic of the today's webinar. That's why I am asking some question.
No problem. No problem.
These questions are very regularly we are discussing in our regular spine surgery during Mamun Bhai, Junaid Bhai, me, and also that's why I'm just asking these questions for our juniors. I'm sorry, I do not know about the today's webinar topic. So my request, Dr. Jia, to before going any webinar, please particularly just you will discuss regarding this topic. That will be good for at least 1 week or 2 weeks before. Then I think it will be good for everyone, and it's a very good start. And I think those people who are starting this type of educational activity, I think everybody will join. And those people who cannot join, you can record a session, you can upload it in your YouTube channel or Facebook. I think everybody will take their opportunity. Thank you very much. Thank you, everybody.
Thank you. Thank you. So this session is already recorded, and we'll share it somehow. We'll find a way. So I would like to invite Dr. Abdullah Mahmoud Chaudhary, today's our faculty, to say his last few words and conclude the session. And from my side, I would love to thanks every participants here. Today almost 30-35 participants we had, and it is a great going for the second session. So I am very happy and would look forward towards the next session. Dr. Mahmoud, please come say something and
থ্যাংক ইউ
conclude.
জিয়া, আসলে তোমাকে অনেক ধন্যবাদ এই ধরনের একটা সেশন আয়োজন করার জন্য এবং আমাকে এখানে কিছু বলার জন্য। অ্যাকচুয়ালি আমরা যে সব জানি সব বুঝি ব্যাপারটা এরকম না। তো আমরা যতটুকু জানি আমরা শেয়ার করতে চাই আমাদের রেসিডেন্টদের সাথে, আমাদের কলিগদের সাথে, সো দ্যাট দ্য ডিফিকাল্টিস, আমাদের যে বোঝার যে আন্ডারস্ট্যান্ডিং এর যে প্রবলেম, যদি কিছুটাও যদি লাঘব হয়, এটাই হচ্ছে সার্থকতা, যে আমরা নলেজটা যতটুকু পারি ডিসেমিনেট করার চেষ্টা করব এবং আমাদের ভুল আপনারাও ধরিয়ে দিবেন, যারা আছেন ধরিয়ে দিবেন, যদি কোনো ত্রুটি থাকে সেগুলো শুধরে দিবেন, কিছু অ্যাড করার থাকলে অ্যাড করবেন। এটা আমি জিয়ার এই উদ্যোগের খুবই প্রশংসা করি এবং তার উত্তরোত্তর সাফল্য কামনা করি। এই বলে আজকে সেশন শেষ করছি। ধন্যবাদ সবাইকে। আসসালামু আলাইকুম।
জি, ওয়ালাইকুম আসসালাম। Thank you, Mohan bhai. Thank you all. Good night.